In order to prevent the development of childhood allergic diseases, an infant's immune system must be mature from a Th2 to Th1 dominant response through the microbial contact soon after birth. In comparison with the time before antibiotics and common presence of infectious diseases, along with the widespread use of antimicrobial agents in consumer products like soap, individuals in the modern times have a reduced contact with these microbes. In the theory known as the hygiene hypothesis, scientists speculate that an antiseptic environment results in a lack of microbial stimulation to the gut immune system, and this causes an increase in allergic disease. In fact, studies have shown that non-allergic children have higher levels of bifidobacterium and lactobacillus compared to allergic children. The presence of these harmless probiotic bacteria in the intestinal biota seem to correspond with a protection against allergies. As defined by the World Health Organization, probiotics are live microorganisms which, when administered in adequate amounts as part of the food, confer a beneficial health effect by producing gut microflora on the host. Many randomized trials, clinical and experimental studies, and meta-analyses have been conducted on the efficacy of probiotics on the treatment or the prevention of allergic diseases. Randomized control trials have shown using probiotics provided a significant clinical benefit to children with allergic rhinitis. Heat-killed or live Lactobacillus casei decreased the frequency and the severity of nose and eye symptoms, and it improved the quality of life in children who are sensitized to house dust mites. Among preschool children with seasonal allergic rhinitis, the L. casei was also found to reduce the symptoms and the number of episodes, and to lessen the use of relief medications. The effect, however, was not statistically significant for asthma. Similar positive effects were observed among children with pollen-sensitized allergic rhinitis who were treated with oral Bacillus cloci spores. Studies that examined the effects of probiotics at the level of the immune system also showed some positive effects. Supplementation with L. gasseri significantly reduced the serum immunoglobulin E specific to Japanese cedar pollen in children with seasonal allergies. Positive effects were also observed among patients who received Bifidobacterium longum. Moreover, this seems to suppress the Th2 cell attraction and activation, and it suggests it might be effective for blunting the immunoglobulin E mediated allergic response. In a 28-week trial, it favorably modulated the intestinal microbiota, lessening the burden of allergens in the subjects with cedar pollen allergies. In an experimental model, it shunted the cytokine profile in favor of the Th1 and suppressed the immunoglobulin E levels, both markers of and contributors to a lessened allergic response. In two randomized control trials studying the clinical effects of L. plantarum, the eosinophil count decreased immediately after the intake in the group that took it, and the percentage of the Th1 helper T cells increased after 6 weeks. It also strongly induced the gene expression of Th1 type cytokines, indicating that the probiotic is clinically effective in the management of seasonal allergic disease. A review of 13 randomized control trials on the effectiveness of probiotics in the treatment or prevention of atopic dermatitis found, regardless of the immunoglobulin E sensitization, that L. rhamnosus and other probiotics were effective for preventing the atopic dermatitis. The probiotics also reduced the severity of the dermatitis in half of the trials evaluated, although there was no significant change observed in the inflammatory markers. One study demonstrated that skin severity scores were significantly lower in the group who were given the heat-killed L. paracasei, and the placebo group used nearly double the amount of topical medicine during the study period. Similar positive results were observed among preschool children with moderate to severe atopic dermatitis who were treated with supplemental probiotic mixtures. The absolute count and the percentage of the CD lymphocyte subsets in the peripheral blood also decreased in the probiotic group. On the other hand, a randomized trial showed prenatal treatment was not sufficient to prevent eczema among the infants in the first year. In terms of preventing allergies, a meta-analysis of 6 studies reported significant benefits in infants who were at a high risk of allergy who used probiotic supplements containing L-rhamnus. A recent study demonstrated that infants with suspected cow milk allergy who were given partially hydrolyzed infant food supplemented with a probiotic had a higher probability of acquiring a tolerance to the cow's milk at 6 months when compared to the infants who were not given the supplementation. In addition, skin patch test response were negative in the infants who had acquired the tolerance. Clinical improvements have been reported among patients with allergic rhinitis and immunoglobulin E sensitized atopic eczema, but studies on the efficacy of probiotics in the management of asthma remain inconsistent. Possible reasons include difference in the study design, type of probiotics used, and the duration of the probiotic supplementation, which limits the comparability of the results. A specialized dried yeast ferment of Saccharomyces cerevisiae, called Epicor, was shown to reduce seasonal allergies in 2 small studies. In one study, 25 healthy participants consumed the Epicor or placebo every day for 5 weeks during the allergy season. The placebo group experienced increased seasonal allergy frequency, but the Epicor group did not. Interestingly, allergic symptoms returned within 1 to 2 weeks after the participants stopped taking the Epicor. In a large study, a daily dose of 500 milligrams of Epicor or placebo was compared in 96 healthy subjects with a history of seasonal allergies. Subjects in the Epicor group had less severe nasal congestion and runny nose, and they used less allergy medication than those who were taking a placebo. Allergies are mediated in part by an immune signaling protein called immunoglobulin E. If the immune system produces too much immunoglobulin E in response to a stimulus, an allergic reaction can then ensue. A strain of Lactobacillus acidophilus called L92 was shown in a preclinical screening study to reduce the production of the immunoglobulin E in mice who were challenged with a pro-allergic substance. Based on these intriguing results, 3 clinical trials of L-acidophilus 92 were carried out. First, the L92 was administered to subjects over 2 allergy seasons. Doses were 50 billion colony-forming units twice a day for 6 weeks during the first season, and 20 billion colony-forming units once a week during the second season. 23 people participated during season 1, and 20 did in season 2. During the first season, the L92 reduced the eye-related distress related to allergies by 31%. During the second, a statistically significant reduction in overall allergy-related distress among the subjects was observed. In the second study, 49 participants with allergic rhinitis took either 30 billion colony-forming units of the L92 or placebo every day for 8 weeks. The nasal mucosal swelling decreased by 24% at week 8 in the L92 group. Also, the nasal symptom score decreased by 19% in the L92 group compared with the placebo at week 8. In the third and slightly larger study, 80 subjects who had a cedar pollen allergy and were exposed to cedar pollen at baseline took the L92 or placebo for 8 weeks before the re-exposure to the cedar pollen. This led to a significant reduction in the nasal and eye allergy symptoms compared to the placebo upon the re-exposure. In recent years, there's been an increased interest in the role that vitamin D plays on the immune system, and in particular, allergic disease. It's known that vitamin D receptors are found in multiple tissues and cells of the human body, including mononuclear cells, T lymphocytes, and dendritic cells, which are important in the recognition of antigens. Vitamin D also has multiple cytokine modulating effects, and it can decrease the proliferation of both Th1 and Th2 cells, and it can lower the production of interleukins and interferons. Vitamin D has also been shown to have a role in the airway remodeling, which might be important in understanding and treating asthma. Molecular studies also provide evidence that vitamin D can modulate inflammatory responses, enhance antimicrobial peptide activity, and promote the integrity of the permeability barrier of the skin. Epidemiological studies have revealed vitamin D deficiency is associated with an increased incidence of asthma and allergy symptoms, higher immunoglobulin E responses to food and environmental allergens in children and adults, and severity of atopic dermatitis. Similarly, children with well-controlled asthma were found to have higher levels of vitamin D, and adults with chronic urticaria or hives have lower vitamin D than the controls. A randomized control trial involved 45 atopic dermatitis patients, and it provided evidence for the beneficial effect of vitamin D and E supplementation on the clinical manifestations. The symptoms scored significantly improved in the treatment group for the vitamin D and vitamin E. On the role of vitamin D in preventing asthma and atopic disease, studies have demonstrated that women with a high intake of vitamin D during pregnancy lower the risk of their child developing wheezing or rhinitis at age 5. This correlation was found in different populations, regardless of the amount of vitamin D intake. A prospective follow-up study showed conflicting results. A recent longitudinal study demonstrated vitamin D as a predictor of asthma in later years. The study involved 689 children from a cohort unselected for asthma, and they were examined at age 6 and again at 14, and it showed among the male children inadequate levels of vitamin D is a risk factor for developing bronchial hyperresponsiveness and asthma. More importantly, vitamin D levels at age 6 were predictive of the asthma-associated phenotypes at age 14. Although many epidemiological studies over the past decade have clearly identified a link between vitamin D levels and asthma or atopic dermatitis, such studies have limitations and they can't establish a causality. A clinical trial examining whether maternal supplementation with 4,000 international units of vitamin D can reduce the incidence of asthma in the offspring during the first 3 years of life is currently underway. Vitamin E is a fat-soluble vitamin, and it acts as a free radical scavenger. It protects the cell membranes and it prevents damage to the membrane-associated enzymes. Research suggests that vitamin E inhibits the activation of neutrophils, cells that contribute to respiratory inflammation in the asthmatics. Studies also indicate that vitamin E can influence and halt the proliferation of mast cells in culture, suggesting a role for vitamin E in modulating allergies, atherosclerosis, cancer, and other disease in which the mast cells play a role. Several studies provide evidence on the relationship between a vitamin D intake and asthma on allergic disease. A Japanese prospective study reported that low maternal vitamin E intake during pregnancy was associated with an increased likelihood of wheezing in children younger than 2 years of age. A Scottish birth cohort study reported that low alpha-tocopherol intake during the first trimester of pregnancy was associated with an increased risk of wheezing and asthma in 5-year-old children. A case-controlled study reported that childhood asthma is associated with low dietary vitamin E intake, and a 10-year prospective study of adult-onset asthma also reported similar findings. In a clinical study of atopic dermatitis, patients randomly selected to orally receive 400 international units of vitamin E every day for 8 months reported remarkable improvements in facial erythema or redness, and lichenification or scaling and thickening of the skin. Eczemaceous lesions were also reportedly healed as a result of the decreased itch sensation. Animal models have shown supplementation with high doses of vitamin E reduced the proliferation of splenic lymphocytes, the production of interleukin-4, interleukin-5, and total serum immunoglobulin E levels. Sneezing and nasal allergic response were also suppressed in the treatment group. In a randomized control trial, patients with seasonal allergic rhinitis who received vitamin E supplementation during hay fever season experienced improvements in their symptoms. Vitamin C as ascorbic acid increases the function of many immune cells, including the T cells, phagocytes which destroy pathogenic organisms, and others. As an antioxidant, the ascorbic acid protects the cells from reactive oxygen species that are known to cause tissue damage and disease. Vitamin C has antihistamine properties and it can help to relieve allergy symptoms, but the evidence is still controversial. Early studies demonstrate 2 grams of vitamin C improves pulmonary function 1 hour after ingestion compared to placebo, and another study found a 5-fold increase in bronchial hyperreactivity among those with the lowest intake of vitamin C. An animal model showed a high-dose vitamin C supplementation significantly decreased inflammation in the lungs. Magnesium is utilized by every cell in the body, and it participates in energy metabolism and protein synthesis. Magnesium participates in at least 350 enzymatic processes in the body. Evidence from animal models indicates that magnesium plays a role in immune response and that a deficiency leads to increased inflammation. Results from randomized clinical trials show that children and adults who were hospitalized for severe acute asthma benefited from using intravenous magnesium sulfate. One of these studies used a higher dose of magnesium sulfate at 40 mg per kg, and it observed a faster and more prolonged improvement in the pulmonary function. A randomized study found taking 200 to 290 mg of magnesium for 4 months significantly reduced the use of bronchodilators in children with mild to moderate asthma. Similar beneficial effects of 12 weeks of magnesium supplementation were found in a small study involving children with moderate persistent asthma who were treated with inhaled fluticasone. More recently, long-term treatment with oral magnesium at 170 mg twice a day for 6.5 months in adults with mild to moderate asthma showed improvements in objective measures of bronchial reactivity and in subjective measures of asthma control and quality of life. Fish oils contain the omega-3 fatty acid DHA and EPA. And EPA and DHA exert anti-inflammatory and anti-thrombotic or anti-clotting effects because the omega-3 fatty acids compete with arachidonic acid, which is converted into pro-inflammatory eicosanoids. Studies suggest that fish oils reduce the production of inflammatory cytokines such as interleukin-1, interleukin-2, and tumor necrosis factor, which are all involved in the allergic response. Additionally, lower levels of omega-3 fatty acids in the blood are associated with delayed type hypersensitivity skin reactions in elderly malnourished subjects. In one study, an ointment that contained DHA and EPA produced satisfactory results in 64 patients with refractory dermatitis. A systematic review of maternal supplementation with omega-3 polyunsaturated fatty acids found evidence that they reduced the prevalence of childhood asthma, but supplementation during lactation did not prevent asthma or food allergy. Intake of polyunsaturated fatty acids among 1,002 pregnant women showed a tendency towards lesser allergic rhinitis in the children. It suggested the omega-6 to 3 ratio should be kept at around 4:1 for optimal health. For more on allergies, herbs, supplements, or natural treatment plans, check out my website.